Well, for those on our Zoom audience, this is the first live session we've had since March of 2020. Drew recorded that date, I guess,
March 3rd.
March 3rd of 2020. I won't go into all the details, but it was quite a battle for me to get the head of our division to actually allow us to have live sessions again on a small basis. So I can't invite everybody, but I'm glad we have a large Zoom audience this morning, and people are just socializing. People haven't seen each other in person for 2 years. That said, we've got a guest speaker today from San Diego. It seems like over the weekend and then today, we basically needed a refresher course from the immunologists down in San Diego. Most of the speakers at the Northwest Allergy Forum were from San Diego. Now we've got another. I guess we're falling behind the curve up here. And so it's happy to have Bob Geng up here to give today's presentation on understanding immunoglobulin therapy. We had him as a speaker at a dinner last night, and the audio visual was a total failure. He just talked off the cuff and did a fantastic job. Today, we've got the AV working, so we can have a more formal presentation. So thanks for coming. All right. I'll give you the stage here.
Thanks so much, Len. Really appreciate it. So, it's when Len invited me, I was really excited to come up because I was just telling Len that, he touched me in a very meaningful way when I was actually a first-year fellow. So back in those days, the Academy had a program where they would match up a first-year fellow with a senior faculty from somewhere based on your interests. And it's like a little matchmaking. And you would basically be matched up with somebody, and that person was going to be your chaperone through the Quad AI, because the Quad AI, I think it's still going to be pretty big this coming year, but pre-pandemic, it is humongous. And going through that is very intimidating for a first-time person. So Len was basically like my chaperone guide through my first Quad AI, and that was a lot of fun. And I didn't remember much, but one of the things I did remember was he told me, whatever you do, you have to go and see the Concours d'Elegance in Pebble Beach. And for years, I didn't get a chance because it's expensive. It's like $450 just for the lowest level tickets. So not this year, but the year previously, I actually finally went with my girlfriend, and we had a blast. We thought it was amazing. And when we were there, it was just like, wow. I mean, like, kept on remembering back to the person who told me about that.
I didn't teach any medicine.
No, but I mean, cars. I mean, that's more important. So anyhow, so so I missed the colleagues in my division by about a few days, because over this weekend I was actually presenting in your Washington State Dermatology Conference in Sancadia. But that's why I joke around. I say I see my colleagues in my division more so in meetings and conferences than I do in our own division meetings. And so my name is Bob Geng. I'm an associate clinical professor in allergy immunology in departments of medicine and pediatrics. And I spend half the time in research and the other half the time in clinical practice. Do a lot of clinical research as well, some translational research as well, in collaboration with some of our basic science colleagues, and do a number of both sponsor clinical trials as well as our own investigator-initiated type of studies too. So we do a lot of fun things. And I run an asthma center, an eczema center, but we also have a very robust PID program as well. But it's not just about primary immune deficiency anymore. I think that what's really exciting is that we've now have become sort of the tertiary immunology consultants for a lot of other specialties. So in many ways, we're getting more and more secondary antibody deficiency patients from rheumatology, hemonc, solid organ transplant especially, and I think we should embrace it. And in fact, I mean, another side gig that we picked up along with one of my other colleagues is running an immune surveillance program for pediatric solid organ, kidney, and liver transplant program in our hospital. So we're monitoring their their immunology parameters, trying to get ahead of the game rather than be behind the 8 ball when they get into trouble. So I think that's one side of things. And the other side of things is also the fact that primary immune deficiency disorders and immune dysregulatory disorders, I think, are beginning to become more and more blurred. I think really immune deficiency, immune dysregulation are two sides of the same coin. And we're seeing more and more of our patients have elements of both. And it really allows us to have a better understanding of how the two parts of our specialty can come together very well. If you think about it, our CVID patients, about 50 to 70% of them will eventually develop chronic lung disease. And many of them, around 75% of those patients are going to have chronic lung disease of an obstructive type. What do you call that? Do you call that asthma? Do you call that COPD? I mean, it's hard to say. But the thing is, they have that kind of phenotype. So, I mean, many of those patients are on inhalers. We have to do pulmonary function testing. On the other side of things, I mean, we also have, going out the upper airways, about 10% of CRS without nasal polyps may have an antibody deficiency component as well. So you think about some of the conditions that we typically associate with atopic inflammation or eosinophil inflammation. Some of them may also have non-type 2, non-eosinophilic basis as well, that's driven by chronic inflammation and recurrent infections. And of course, conversely, we also have the immune dysregulatory individuals. Think of the DeGeorge patient or the IgA deficiency patient. Many of them have increased rates of atopy as well. So the thing is, that's why we kind of have to understand how we think about these things. Take a patient like a Job syndrome patient. On the one hand, you can understand that as an IL-17 deficiency type of individual. But on the other hand, you can also see a Job syndrome patient as a hyper IgE syndrome patient is almost the highest and most extreme skewed version of extreme type 2, immunity. So there's different ways of seeing this and different ways how the two sides of our specialty can come together. But today we're actually going to talk a little more about some of the nuts and bolts of understanding the origins of immunoglobulin and what we use it for. And we're going to go through some of the things that we're comfortable with as immunologists and what we've done. And then we're going to go into some of the other areas where immunoglobulin is used that we may not be as comfortable with, but we really need to, because we're the experts on immunology and we're the experts on using immunoglobulin. And increasingly, we're having other specialists like neurologists and rheumatologists and hematologists ask us questions about utilizing immunoglobulin therapy for immunomodulatory purposes. So we're going to touch upon that. We're going to go through some of the evidence behind what we do from a replacement standpoint, as well as go into understanding it from immunomodulatory standpoint. So today's the word of the day, I guess I was told to say universe. So I have a number of disclosures, and you can see it from the email as well. I advise most of the plasma manufacturers from Takeda, Grifols, Kedrion, BPL, and ADMA, and even the people who deliver, make devices to deliver immunoglobulins, such as Kuru as well. So we start out with a little bit of shrouded sky that's, there's a bit of a light at the end, but it's kind of covered by a lot of clouds. This is actually a picture taken on one of my trips to Teddy Roosevelt National Park in North Dakota. And you discover that even in the most remote places, you can find beauty. And so from an outline of the discussion today, we kind of talked about, we're going to go through the overview indication of immunoglobulin therapy. We're going to talk about where this comes from, because a lot of people don't really know, and especially for our fellows, kind of understand that this is not a manufactured product, even though we use the word manufacturing. Comes from folks like you and me. It's not artificially made, and we have to appreciate that because it's a finite resource on an annual basis. I don't remember the time when there was a shortage, but I'm sure that some of our more senior colleagues may remember the days of shortage. So it's a finite resource, and we want to make sure that we understand that it's a precious commodity and how we utilize it. And in fact, I mean, it is a precious commodity. On a price point, it costs more than gold, actually. So, and if you do it per ounce, it costs more than gold. So that's why, like, I mean, like, so it's something that we have to be cognizant of, and understanding where it comes from, where it has to be moved around, and who needs to utilize it gives us a greater appreciation that not everyone should be on it or need to be on it, and we really need to look at the patients who really need to be on it. And then we're going to talk about intravenous and sub-Q administration and some of the pharmacokinetics, as well as some of the data behind the differences, and then dosing of immunoglobulin. And we're going to go through some evidence-based medicine on how we dose, and also, of course, the relationship between dose level and efficacy. And the last part is we're going to touch upon immunoglobulin therapy for immunomodulation. So this is a photo I took halfway up Mauna Kea. So you can see the peaks, and below there, it's not the ocean, it's actually clouds. So you see the peaks rising above the clouds and onto really beautiful sunsets. So on that note, I encourage everyone to try to go to the Western Society meeting every year, because that's a great meeting, and that's where I take those photos. So two main rationales for IgUs. Breaks down basically into two main ways. So you have a replacement purpose and you have immunomodulation. And for replacement standpoint, you're low on the tank and we got to fill up the tank. And you can either be primary antibody deficiency or secondary antibody deficiency. And now we're up to, I think, over 400 primary immune deficiency disorders. But not all of them are antibody deficiency. About 2/3 are predominantly B cell defects or involved B cells, and about another 15% are combined T cell and B cell. So about 85% of these patients have some degree of primary antibody deficiency, and the rest are probably pure cellular deficiencies as well as innate immune system defects. And secondary antibody deficiency, that's an area where it's growing significantly because we have more and more targeted precision medicine that is in the field of oncology, autoimmune disease, and on the one hand, they suppress excessive inflammation, but on the other hand, they may have some downstream effects of decreasing our normal immunity as well. So a more nuanced approach to that and better understanding of that is going to be really helpful. So, I mean, we now have patients who got one dose of Rituxan 10 years ago and still was hypogam and is seeing us. And so the thing is, some of these impact on anti-B cell therapy may have long-lasting effects way beyond what we've understood before. And secondary antibody deficiencies, I mean, we're beginning to have more understanding and awareness from our colleagues in solid organ transplant, hem-onc, as well as rheumatology. I think that we started our collaboration with solid organ transplant because they have a lot of coordinators, and they know their patients like the back of their hands. So that's why it's really well characterized cohort. Whereas you go to a lot of rheumatologists, I mean, they can barely keep track of who's on immunosuppression, who's not. So that's why it's easier to kind of work with the transplant people first to be able to generate the data to then go back to apply the same type of model. But the thing that we keep on emphasizing to all these other specialties is don't send someone to us after you blasted their immune system and wonder whether it's a PID or an SID. I mean, because then I have no idea. So you need to make sure that before you start anti-B cell therapy or any significant immunosuppression, why don't you check some baseline labs so that later on, if the patient does get into trouble and you send them to us, we have something to work off of. Because rheumatology and hem-onc love doing this, and they send people to us and then ask the chicken and the egg question. And I said, well, I mean, like, you got to give me a little more information a priori. So I think we've done a better job training people in our own institution, but I think we still have a long way to go from a national standpoint. Immunomodulation. So this is the laundry list of things that IG is used for that typically we feel that we're oblivious to and we don't really know much about, but we do need to know more about them. And I'll tell you why. So 40% of IG that's used in this country are used for immunomodulation. So a significant portion. And so we have to understand and appreciate why and they're used for this. So from a neurology purpose, they're used for an acute basis for Guillain-Barré, chronic inflammatory demyelinating polyneuropathy, CIDP is the acronym. And then you have myasthenia gravis, multifocal motor neuropathy, MMN. So it works in a variety of different ways. So it's very simple to understand how IG works from a replacement standpoint. You know, you're low, we give you back more. But for immunomodulation, the concept is we want to give enough to overwhelm the autoimmune response somebody has. And it's easy to say as a general concept, but how does it actually work? And there's many, many different ways in which it works. And we'll touch upon that towards the end of the talk. But the thing is, there's novel therapies that are coming out that target one specific element of how it works by trying to block the FcRn receptor and by increasing the degradation or decreasing the half-life of antibodies. And it works very elegantly in conditions like myasthenia gravis, when it's a very simple condition. You remember back in first year medical school, that's one of the first type of disorders that's taught. It's like the simple model of one bad antibody, one receptor, one disease. So it's a very straightforward type of thing. So if you do something to decrease the half-life of that anti-acetylcholine choline receptor, then antibody, then what you do is you're able to decrease the pathogenesis and restore function. So in something that simple and that elegant, you can potentially just target one of the ways immunoglobulin works. But if you start looking into things that demyelinating disorders that may engage in parts of the innate immune system, T cells, as well as humoral immunity, it may not be as simple anymore. In rheumatology, they use it for dermatomyositis. For hematology, you use it for ITP. And it's interesting because ITP is actually a very common non-infectious complication of our CVID patients. So there may actually be quite a bit of overlap from our CVID patients who may also have concurrent ITP. And we'll talk about that in some of my personal experiences on what we can do in those types of patients who may have chronic ITP. And then of course, from a dermatology standpoint, they use it in addition to dermatomyositis, who they're also secondary consultants for, and we share some of those patients with them as well as rheumatology. They also use it considerably for bullous disorders, bullous pemphigoid, pemphigus vulgaris, again, targeting that autoantibody. And but it's not necessarily as simple as just looking at the autoantibodies. Kawasaki's disease. So we have to recognize that that a lot of colleagues in our division, Dr. Jane Burns and all, who've been pioneers in this area and who actually did a lot of the original studies on IVIG and Kawasaki's disease as well. And then the problem is in a pediatric hospital setting, the cardiologists, a lot of times when they see IVIG, they're like, oh, we're going to give the 2 grams per kilo in immunomodulatory Kawasaki dosing, where when they look at our patients who may have protein-losing enteropathy and only need a replacement dose, they don't understand the dose differences between a replacement dose, which is the low dose, and that ranges between 0.4 to 0.6 grams per kilo, versus immunomodulatory or high dose, which is between 1 to 2 grams per kilo. And you can really get yourself into trouble with a lot of adverse reactions if you ended up excessively dosing some people, because there are certain adverse reactions that are going to be more of a dose-dependent fashion. And of course, solid organ transplant uses it for a variety of different reasons. We talked about secondary antibody deficiency, but on a immunomodulatory standpoint, they use it for antibody-mediated rejection as well. And that's what they consider to be a major part of chronic rejection. And they may also use it for what they call, I believe, induction, which is if they can't find a complete matched donor, they would give someone high dose IVIG so that you can desensitize somebody to not have as many antibodies against the donor graft. And so there's a variety of ways that solid organ transplant would use it. And of course, in allergy as well, the jury is still out in how well it works in Stevens-Johnson syndrome. And even their case report, case series on the use in atopic dermatitis. And of course, even in DRESS syndrome, there's actually a nice paper that came out a couple of years ago, I believe, in JACI in Practice. It was a case series on the use of acute DRESS syndrome. And we've actually successfully used it in the case of chronic DRESS syndrome patients as well. So lots of different immunomodulatory uses. So PID. So PID, we all know the story. It was first described in 1952 by Colonel Ogden Bruton. And it's interesting because the other day I met Dr. Tim Sullivan in Utah, and he was actually trained in the military as well. And he actually told me that Dr. Bruton did not actually see this patient, that he just was the ranking officer, so he was the senior author. And back then it was a ranking officer who ended up becoming the senior author. And because he got to be the senior author, the syndrome got to be named after him. So it was actually other people who saw the patients, like, that's very interesting. And but it was about a young boy with recurrent respiratory infections who couldn't make specific antibodies, but was successfully treated with immunoglobulin. So that's where the name stuck. And the prevalence in PID in this country is 1 out of 2,000 patients, and the incidence is about 1 out of 10,000 patients. So it's not considered to be a rare disease by the FDA, nor should you consider this to be a rare disease. Any individual, see, I have to update these numbers all the time. There's more than 400 characterized PID syndromes now, but any of these individual ones may be considered a rare disease if you took WHIM syndrome, APDS. These are considered to be rare diseases. But as a collective of primary antibody deficiency or primary immune deficiency disorders, it's not considered to be a rare disease. And we have to have a lower threshold to think about it and to test for it, rather than thinking, oh, it's something that I'm going to see in training once and I'm not going to really see it again. That we really need to dispel that notion. We also need to dispel certain notions that it's a pediatric disease. The last time we looked at utilization of immunoglobulin for primary immune deficiency, the majority of IG is actually used in adult PID patients. And the majority of those are actually taken care of outside of major academic centers. So the thing is, we have to do a much better job in educating everyone in the community who are seeing these patients to be more assertive in looking for it, thinking about it, and testing for it. And the Invitae PIDD panel is actually really nice. Every year it's been increasing. So a few years ago, started at 217 genes, and then it went to 300, then it went to 400. And now I just realized that the recent patient I got the results back was actually up more than 500 genes that were tested. And we no longer really even want to use the word PIDD anymore. So in the Clinical Immunology Society meeting earlier this year, I think the consensus is that between CIS and ESID, which is the European Society of Immune Deficiencies, kind of setting the standard, is that we really want to replace it with the term IEI, which is inborn errors of immunity. So that encompasses both immune deficiency as well as immune dysregulation. And so really now it's called the IEI panel, so that we kind of look through all these different things. And the other thing I want to mention is, for all the people who are interested in research and our fellows, sort of understanding how it's from our immune deficiency patients, our IEI patients, that we have a better understanding of immunology. So in basic science, you have knockout mice. So who are the knockout humans? Many of these knockout humans of immunology are really our primary immune deficiency patients. So case in point here, Bruton's. So it wasn't until decades later that they discovered that it was a defect in Bruton tyrosine kinase, a major step in B cell maturation. So guess what? Now we understand that they're able to do further research on this and turn BTK inhibition into a potential therapeutic target for treatment refractory lymphoma, as well as now even looking at chronic urticaria. So the thing is, BTK inhibition has now become a major target for therapeutic research. So same thing, I mean, like if you think about other things, I mean, where does all the IL-17 blockers, the thing secukinumab and rodalimab, well, all that came out of our Job syndrome patients, understanding that's how we discovered IL-17. And all the things that engage in regulatory T cells. So that came from our IPEX patient where we discovered FOXP3, which is was the defect in IPEX, and you end up having no regulatory T cells. Same thing now, I mean, with some of the innate defects, our IRAK4 deficiency patients. Now that has become a target for a lot of rheumatology therapeutics as well. So I think as we understand each of our inborn errors of immunity is also another opportunity to look at that from the flip side of that and see how that can be used for therapeutics. All right, so this is a breakdown of PID conditions. We already mentioned this. And this is something that you're all very familiar with, the various common antibody deficiencies, CVID being the most common one that's described. It's basically a wastebasket term. It's like asthma, COPD. It's like we describe a phenomenon, but we really don't understand the mechanism. Over 90% of CVID patients, we have no idea what is the underlying genetic cause. And not always sure that we necessarily need to do underlying genetic testing for every CVID patient. We do need to look at genetic testing for CVID patients who are not doing that well. So this is a kind of a sharp departure from some of my colleagues. If you talk to Dr. Manish Butte at UCLA, he's going to say, basically he has the receptionist call every hypogam patient to come in, and he's going to get each one of them sequenced. And so the things, and we're part of a study with him right now as well, that involves multiple sites in California trying to sequence almost all our CVID patients, because we do need to understand that from a research perspective. But most of these, when you run the exome, you don't really find anything. It's because the majority of CVID patients are not monogenic, not of a monogenic etiology. So you're not going to see, oh, there's one gene that's defective or a few genes that's defective. It's probably many VUSs, hundreds of thousands across multiple genes, and they're linked in some mechanistic fashion. So that's why it's helpful to look and do genetic testing for CVID patients if they're not doing well. So I'm sure many of you have seen, I mean, there's a well-documented paper that was published now probably a decade ago, and it's quoted very often, and you see the Kaplan-Meier curve of CVID patients. Many of them do really well on immunoglobulin therapy. These are the ones who are usually hired as patient advocates by the manufacturers. They stand by the booth and they go to more dinners than you or me, and they're whining and dining. These people don't need genetic testing. They're doing just fine. But you also have the rest of them, many of them who end up with autoimmune disease, potential malignant complications, and GI complications. And these patients start spiraling the drain and get worse and worse and worse, and their survival isn't great. And it's not just about survival, it's also about morbidity as well. And those are the patients where we do want to take a deeper dive, because when we do genetic testing for a clinical purpose, we have to have a purpose. So it's from a research standpoint, I agree. We should try to sequence as many of these people possible to try to map out, what are the patterns? How can we better understand the basis for CVID patients? But from a clinical standpoint, if we're suspecting that there may be targeted interventions, like if you have find a STAT1 gain of function, STAT3 gain of function, APDS patient, WHIM patient, CTLA4 haploinsufficiency patient, LRBA patient, any of these people where we may be able to look at targeted therapies for them, I think there's real clinical benefits in doing sequencing. So we have to be a little bit judicious on that. Although now, with free testing, because there's many of these rare disease companies now are giving a lot of money to Invitae to provide, if you meet a few criteria, and they're very loose criteria, you can basically get free testing for 520 some genes on the Invitae IEI panel. And you should take a look at those, because I mean, a lot of our patients can fall into that category if you're curious and you don't want to go through the insurance and you don't want to have to pay for it. So I think we all know what specific antibody deficiency is. Agammaglobulinemia, just one key point is that it's not just Bruton's. 15% agammaglobulinemia patients are actually girls, and they have an autosomal recessive hereditary pattern. Hyper IgM syndrome patients, it allows us to understand the key concepts behind class-switch recombination, which is really important, and the transient hypogamma of infancy. That's also something that's interesting, because that's a departure on what people say at the podium versus what people do in real life. People say at the podium that, oh, this is a transient issue, you can just monitor, you don't need to replace. And but then when you're actually seeing these patients, and many of them could have significant history of infections, it makes practitioners kind of nervous and want to end up replacing. Same concept as protein losing enteropathy too. At the podium, the speakers will all say, well, you know, it's making it fast enough that the turnaround is sufficient. But on the clinical level, a lot of people still end up replacing. I mean, if somebody sends you a nephrotic syndrome patient with an IgG of 200 and had a few cases of infections, you're going to feel pretty nervous about not replacing. But I mean, if you look at the guidelines, they actually say, well, you know, you can kind of watch and wait on some of those individuals. So it's what you can say at the podium without any liability versus what you actually do in clinical practice. And IgA deficiency is actually very common. 1 out of 400 people have IgA deficiency. People who are Scandinavian origin have a higher rate of that. And so it's one of those links between ATP, autoimmunity, as well as immune deficiency as well. And the vast majority of these patients do fine. We don't even know they walk around with IgA deficiency. All right, so, you know, we do a lot of preaching to the choir, and sometimes we got to be aware that we have to preach outside the choir as well. So years ago, Mel Berger, who was actually head of pediatric allergy immunology at Cleveland Clinic, I believe, and later on he became global medical director for CSL Behring. He and I wrote a paper together, and we deliberately published this in Respiratory Medicine because we want our pulmonary colleagues to read it. Because we have to think beyond just infections. I mean, I think Jeffrey Modell Foundation's 10 warning signs are a little antiquated. I think we've been repeating them over and over and over again. And we need to tell them that, you know, you need to actually start looking in other kind of comorbidities. I don't even like calling them comorbidities, because comorbidities is saying that we think they just kind of happen on the side and it's something unrelated. This is related. I mean, this is because you have pathogenic organisms that are colonizing the airways, and you can lead to chronic inflammation, subclinical infection that's leading to prolonged inflammatory changes. And some of these patients can have a COPD-like picture, some of them can have a refractory asthma picture, bronchiectasis, et cetera. So we have to really look at this and in a meaningful way. And when I was a resident, I mean, in internal medicine, we had so many patients in the VA come in who had recurrent pneumonias. We never checked an IgG level on them. I mean, and in fact, I mean, if you look at the internal medicine boards, there's barely any questions on, I mean, there's questions on Samter's triad, but there's no questions really on CVID. And looking at the patient who has COPD with recurrent pneumonia, we just kind of chopped it up. Oh, you're just on too high of a dose of ICS, and that's why you have this pneumonia. Well, we actually did a review paper that showed that there's substantially higher prevalence of antibody deficiency patients in the patients with chronic lung disease, and not just lung disease, airway disease. So asthma, as well as COPD, and even CRS without nasal polyps. Oh, non-infectious complications. I mean, I'm sure the first bullet point is a bane of many of our existence. That it's something that unfortunately many of our CVID patients and hypogam patients complain about, and we can't really do much for, which is the GI issues. Now, some of them have more of a functional process. They have more of an IBS-like picture, and some of them actually develop more of a frank inflammatory picture, almost looking like a hypogammaglobulinemic sprue almost. And it's interesting how we want to manage these patients. So for the IBD-like picture, people have looked at anti-integrin therapies. I mean, things like vedolizumab to see if we can block some of this aberrant lymphocytes from trafficking into the gut. And there were some mixed results on this. I mean, and some people have experienced benefits, some patients have not. On the functional GI issues, that gets really tough. I have some patients who swear when I increase their dose, they feel better from a functional standpoint, but other people say there's no change at all. And we frankly don't really know, I mean, what is underlying some of the functional GI issues that are associated with our hypogam patients, but we see that happen on a pretty regular basis. So we work closely with our GI colleagues in trying to figure out, I mean, what we can do for these patients. And of course, what's complicating this is if they start developing more protein-losing enteropathy, then we have to potentially adjust how we dose and replace them. And dermatologic, I mean, some of these patients can have significant cutaneous findings, cutaneous granulomas, in some of the patients who may have significant dysregulation. We had a hypomorphic common gamma chain SCID patient who lived into adulthood, and the main presentation is covered head to toe with cutaneous granulomas. And infection was actually only a secondary concern. And of course, on the other extreme, in the little babies, you can see Omen syndrome, the hypomorphic RAG deficiency, and they can look like an erythroderma type of presentation as well. So there's lots of different dermatologic manifestations. And even if you look at some of our, the IPEX patients, I mean, they can present with severe atopic dermatitis. So, and same thing with our Job syndrome patients. So the skin is really the window to understanding the immune system, and we want to take advantage of that. And it's very easy to get tissue level sampling from that. So we want to work closely with dermatology on that respect as well. Rheumatologic as well. So we've known this. I mean, we have patients who have comorbid dermatomyositis, comorbid RA, comorbid lupus, et cetera. So we work closely with our rheumatology colleagues. And sometimes we have to discuss dosing because, I mean, is it appropriate to put them on chronic higher dose to be able to get them closer to 1 gram per kilo so that we're addressing their underlying rheumatologic issue as well as trying to replace them. And of course, I mean, some of these patients are going to be at higher risk for developing lymphoma as well. And so we have to be cognizant of the potential cancer risks. So in CVID patients, for example, we want to be able to get a baseline CT for them just to assess underlying potential for bronchiectasis if they have respiratory symptoms at baseline the first time you're evaluating. But we certainly don't want to get an annual CT on these people because they are going to be an increased risk for lymphoma. We don't want to radiate these people all the time. Neurologic as well. So we're just beginning to understand the neurologic aspect of things and how they can potentially work. And we have more and more neurologists say, you know, occasionally they would check baseline antibody level for their CIDP patients, and sometimes they find that these patients are actually hypogam. And I tell them, well, it's not that strange of a concept considering that many of these demyelinating disorders are autoimmune in nature. So if you can have autoimmune joint disease, why can't you, and autoimmune hematologic disease, why can't you have autoimmune peripheral nerve disease? So I think that it's not necessarily strange, but it's something that we are just beginning to recognize. Of course, we already discussed lower and upper respiratory disease. So this is a study that two previous fellows actually worked on with me, and one actually worked on with me as a senior resident, and both of them are now, one of them is now an attending at Scripps, Dr. Wallberg, and Dr. Dilley, who's one of our second year fellows, recently just published this paper. This actually came out of the poster, but we now have a publication that came out earlier this year looking at over 3,100 primary immune deficiency patients on immunoglobulin replacement therapy, looking at 31 comorbidities. And some of these things are things that we consider known knowns, and some of these are unknown unknowns. So if we look at respiratory disease, I mean, across all deciles of life, there's basically between 40 to 60% of a comorbidity with something coded with asthma or COPD on their claims data. But there's also things that, I mean, are less well known, such as some of the neurologic issues, as well as even some of the metabolic side of things that we're trying to just beginning to tease out. So if you actually look at the paper, it breaks it down based on the specific ones that are much higher than the general population in terms of incidence and prevalence level. And it breaks it down and between the genders as well. So you can kind of see, and breaks it down based on age. So you can see a more granular type of analysis. If you take a look at the paper, its first author is Dr. Michelle Dilley on this one.
You assembled such a big group of patients, they're all from the UC system?
No, so that was, so this is actually one of the nice points about collaboration with industry, actually, because there's a lot of HEOR departments in different companies that they buy massive amounts of claims data from payers. And the claims data will have all the different, I mean, insurance companies have a lot of data. And a lot of the pharmaceutical companies will buy massive amounts of data from insurance companies. So they don't really know what to do with other than to kind of look at utilization. But because they have that data, they have health economic outcomes research groups that are constantly looking to engage with academia to see, well, we have all this data. Is there something you want to do with this? I mean, and so they were able to, that one was actually sponsored by Grifols. I mean, they were basically able to purchase all that data from multiple insurance companies and clean up that data and then say, hey, look, is there something you want to do with this data? And there's limitations in looking at claims databases, but it's also something that allows you to give you such huge power to be able to look at massive numbers of people. The next stage of that is be able to couple claims databases and tie that into quality of life data as well as EMR data. Because the thing with claims data is it doesn't go deep enough, it's very broad. But I mean, if we can tie it into EMR data, then that gets a little deeper as well. So I think that's sort of the next wave in kind of being able to do this, but it is something that's helpful. It's a very nice, fruitful kind of industry academic type of collaborative initiative that if any of our fellows are looking at these things, and here, there's nice research opportunities too. So now we're taking a look at this, I mean, a slightly different direction of manufacturing of immunoglobulin. So we have to understand that immunoglobulin is not a commodity. It's not a drug, it's a commodity. It's a precious commodity. It comes from folks like you and me. You go and donate plasma, and it goes through a 9-month fractionation process. So you basically have to make sure you check for no Hep B, Hep C, HIV, and then they still don't trust the serology. So even if you pass that, they will run nucleic acid testing on batches, and if they find anything, then they toss out the whole batch. So then, and if they find that you're positive something, you're not allowed ever, you're blacklisted on the donation side of things. So in the past, they used to put these donation centers in areas where they consider places of clean living and around the country. And that's what my mentor, Dick Steen. So, I mean, like they used to put it in the middle of the country near college campuses. So yes, they need to have places of clean living, but they also want to make sure that people have an incentive to want to donate, because at the end of the day, I mean, it's called a donation, but you're paid for it. So the thing is, they did that. They put those places in areas away from major city centers because of concerns of Hep C, HIV, et cetera. But now that's all gone to the wayside. Now they're putting them everywhere, and they're just trying to collect massive amounts of this. So you have some manufacturers that are putting plasma collection centers all along the border, actually. So interesting tidbit, all US plasma products have to be made by US plasma. So there's only 2 countries in the world that do not allow importation of IG products, and that's the United States and China. And it has to do with the fact that China implemented that during the 80s for HIV, even though now the rates of HIV/AIDS in China is just as high as anywhere else. Now it's more of a protectionist policy. And in the United States, they implemented this in the 90s with mad cow disease. So essentially, I mean, you cannot get any plasma products in the United States that's from plasma derived anywhere else. However, the rest of the world is now paying for plasma donation. So take Europe, for example, the demand for plasma products is always here and the supply is always here because they're not paying people to donate, because the European Union, with the exception of a few countries, member states, consider it to be unethical to be paying for plasma donations. So who makes up that giant gap? We do. So we are like the Saudi Arabia for plasma. And so 80% of the world's plasma products come from American blood. So essentially, whenever there's shortages and things like that, you remember a few years ago, there was a hiatus or moratorium on new Cuvitru products. Well, that had to do with the fact that at that time, somehow Shire won the Canadian tender. So outside the United States, plasma products, and namely IG, is on tender system because the governments around the world consider this to be almost a strategic commodity that they need. So that's why, like, you have to guarantee different governments that you have government contracts, you need to supply this. So somehow the manufacturer for Cuvitru got the Canadian tender. So all of a sudden, all those grams had to be siphoned to Canada, and there's not enough that's left for American consumers. So they had to put a stop on new starts of that product in this country. So the thing is, so whenever you think about this, all this is about not just US supply, but global supply and where all these things are going. So it's all derived from donors and pooled from 10 to 50,000 donor plasma. So we tell patients, it's like one of those like Verizon commercials you see, your immunity is now backed by 10 to 50 healthy donors. And so it's so you are collecting plasma from all those individuals. And we talked about the donor plasma selection, and it goes through multiple steps: isolation, purification, and viral inactivation. In fact, all the modern IG products go through at least three steps of FDA mandated viral inactivation. And you know, there's screening. We talked about different screening pathways. Some of the manufacturers actually go a step beyond and look at immunoaffinity chromatography to pull out anti-A, anti-B antibodies as well, to potentially decrease the rate of hemolysis, although we don't have any studies from a clinical standpoint that actually show that actually decreases hemolysis beyond other products. And because there's many reasons why you may have hemolysis when you're giving immunoglobulin replacements or immunomodulatory therapy, and having isohemagglutinin in there is just one of the mechanisms. So steps involved in manufacturing, we talked about, takes 9 months, so it's full gestational period, and and this is the reason why we encourage all our hypogam patients to still get the flu vaccine, because you're protected against last year's flu if you're on immunoglobulin replacement therapy, and it goes through low pH incubation, depth filtration, nanofiltration, and then different partitioning fractionation steps: cold ethanol precipitation, octanoic acid fractionation, chromatography. And there are minor variations on this. But the reason it takes so long, and the reason why it's very expensive, it has to do with the fact that we are still fundamentally basing this all on a cone fractionation process, which was developed in 1946. This is using your general organic chemistry principles. I mean, pH and temperature. And you ever go into, like, I would encourage everyone at some point to visit a plasma fractionation plant. So when I was at UCLA, we used to kind of organize an annual tour where all the fellows and any of the faculty who want to come can either tour the Glendale, now Takeda plant, or the Alhambra Grifols plant. And it's a cross between a giant beer brewery and Willy Wonka chocolate factory. And it's humongous. And you see wheelbarrows of plasma proteins. People are just wheeling around that they're dumping. And one vial plasma, you get so much out of it. You get albumin, you get C1 inhibitor, you get alpha-1 antitrypsin, you get the coagulation factors, and you get immunoglobulin. So the most abundant protein in plasma is albumin. So it's often one of those byproducts that are come out of the fractionation process. And the third most abundant protein is actually immunoglobulin. Any idea what the second most abundant protein in plasma is? Looking at the fellows. Fibrinogen. Yeah, so yeah, it has to do with clotting.
Are there any infectious agents that cannot be screened for?
So the thing is, so there's always going to be things that, so we're only screening for known knowns but if there's a novel or if there's an undiscovered bug, we won't be able to screen for it. So it will go through. So that's why the FDA, even beyond the serology and the PCR screenings, they make you go through all these steps. So for nanofiltration, so the low pH incubation technically can kill a lot of the organisms, and the nanofiltration technically is supposed to be small enough where it can filter out prions. However, Creutzfeldt-Jakob is always going to be on the label for every plasma product because it comes from human plasma. You can never completely say it's 100% that everything is filtered out of nanofiltration, but technically they add that step in there to make sure that whatever is not killed by the low pH is not going through that nanofiltration process. But it can never be a 100% guarantee. So they've done studies where they took HIV and they specifically allowed for HIV plasma to go through this process just to see how many fold it can reduce it. And by going through this whole the 3 viral inactivation steps, it reduces by 20 log fold. So that's 10 to the 20th power decrease in concentration, which is significant. And it renders it basically from an infectious to a non-infectious type of concentration.
I hate to do this to you, but we're running out of time.
Okay.
So
How much more time?
You want to hit in the next few minutes?
Okay. So real quick thing, I mean, we're not going to so this, I'm sure many of you have seen before how to give sub-Q IG, and the pharmacokinetic curves of IVIG versus sub-Q IG. You've all seen this. This is also in package inserts as well. You have the peak and the trough for IVIG, and then you have sub-Q IG more as an even keel. And we care about the pharmacokinetics because they underlie a lot of the potential for systemic adverse reactions with IVIG that we don't really see in SCIG. And also SCIG doesn't have the wear-off effect that we can often see in IVIG. And these are some of the review of systemic adverse reactions to IG therapies. And this is the local adverse reactions to IG therapy. A common board question is which one, sub-Q IG or IVIG, has higher incidence of all AEs? And that's going to be sub-Q IG because they're counting every redness, every infusion reaction under the skin, every edema, pain, and you do this on a once-a-week basis. But the more severe ones occur on IVIG. And there's a relationship between dose and serum level. These are studies done by Hans Ochs and who I think is still practicing, right? Yeah. And yeah, he's an interesting character. And then Ann Gardoff was actually in Sweden. And so there's various studies that show you the differences in level, but bottom line is around the 200 to 250 point difference between the trough level of IVIG versus the steady state level in sub-Q. And how we dose convert, the FDA mandates the 1 to 1.37, but that's based on not understanding how immunoglobulins work. And they're just basing this on small molecule pharmacokinetics. So essentially, nobody in the United States actually does this dose conversion, and it's not even on the label for the European Union. And relationship between dose level and efficacy, there's various studies that have been that looked at this, ranging all the way from Chaim Roifman back in 1987, where he kind of established, how the current modern dosing between 500 to 600 milligrams per kilo per month achieve better lung function, FEV1, than the 200, 300, which is the ultra low level. So replacements that we don't use anymore in this country, but in Europe, some places they still use that. But he demonstrated that there was better lung function achieved in the current dosing regimens. And also for patients who have chronic lung disease, you may actually need to dose at a higher level in order to achieve the same trough and a higher trough to achieve the same level of control. And there's a study that was actually done by Jordan Orange where they looked at for every 100 milligrams per deciliter increase in the serum level for IVIG, you get a 27% reduction in the incidence of pneumonia. So that's a nice rule of thumb to quote to patients as well as referral base. And this is a study done by my friend Vinny Bonagora at Long Island Jewish, where he basically showed that different strokes for different folks and one size doesn't fit all. And, everybody may have a different biologic level. Vinny got tired of insurance companies denying claims and lowering the dose. So he drew a line above which when Vinny and the patient won, the patient was asymptomatic. And when the insurance company went and lowered down the dose, then the patient got pneumonia or sinusitis. So who's right? I mean, the payers say you got to keep around, and you only need to keep around 400. And Vinny and the patient are saying, no, we need to actually have a much higher level. Well, both are right. So if you only care about preventing someone from dying in the gutters, and then yes, the payer is right. You just need above 400. But, if in modern first world country, I think we should strive better than that. We want to keep people healthy. And if you want to keep people healthy, you may need a much higher level. So this is the paper coming from Jordan Orange, looking at the relationship between dose and trough. Again, for establishing, for every 100-point increase in the dose, monthly cumulative dose, you get about 121 mg per deciliter increase in the serum level. Nice rule of thumb to quote, but you can see here on the ends of this curve, it splays out. So it's really a ballpark kind of idea. And this is with a derivation of that 27% reduction in pneumonia incidence. And this is a study done by Lucas et al. Looking at the fact that once you want to look at two infections, one infection and no infection. And when you want to get to achieve the no infections at all, then you got to push the IG level even higher. This is looking at both Bruton's as well as CVID patients. And Mel Berger kind of established another study looking at the inverse relationship of IgG and infection rates. And this is another study looking at the dosing rates between the US and the EU, how higher dosing rates in the US, even in the same study design, was associated with some better outcome measures. And we talked about real patient experience in IVIG and sub-QIG, wear off effect, quality of life differences, independence. And this is the only study done by Mikhail Rojavin back in 2016 from the old Privigen data that actually showed some characterization of the wear-off effect, seeing that at the second half the dosing cycle or the last week, you start seeing increase in infections as well as decrease in quality of life. And this is a study done by Angardov looking at the SF36 and quality of life measures between IVIG and sub-QIG. This is a study done by my group, and we actually published this in a different paper. This is actually, now I show you the abstract form, but the publication actually has Christine Antarajan, who's one of the pediatric ID attendings. She's actually first author with me on this eventual publication where we looked at SF36 patients comparing 103 IVIG to 527 sub-QIG patients and seeing some of the key differences. And you actually end up seeing better quality of life across multiple factors and domains in SCIG versus IVIG. And this is a longitudinal comparison. We're able to see a compared to baseline as well. So we're going to skip over some of the technical aspects of this and how do we start. And this is a photo I took after IACI in Vienna, Austria. After all that, and start beginning with shrouded clouds, and then the rainbow comes out at the end. So really quickly, in about a 5-minute crash course, we're going to just talk briefly about immunomodulation of IG. So this is something that we don't really know the exact mechanism. There's a variety of different concepts. IG is the only non-immune suppressive immunomodulator. And that's something that's really important to remember. It potentially can neutralize autoantibodies. And specifically for ITP, it can increase phagocytosis of the red blood cells and decrease phagocytosis of platelets. And that's one of the mechanisms that can work. It can saturate the FcRn receptors to increase catabolism of IgG molecules. And that's why many companies are creating clones, FC fragments to use instead. But one of the problems is that what happens is that you then decrease the half-life of not just the bad antibodies, but you decrease the half-life of all antibodies, and you turn an autoimmune person you turn a CIDP or a myasthenia gravis person into a CVID patient or a hypogam patient. So, or even a specific antibody deficiency patient. So you got to be careful how you think about that. And we want to encourage the neurologists to start checking baseline levels more and more so. And there's also, of course, downregulation of antibody synthesis. And we have some data now looking at the induction of regulatory T cells. And one of my basic science collaborators, Dr. Ben Croker, through MISC during COVID, and thinks that he may have discovered even a novel way of how Ig may potentially increase neutrophil apoptosis and have an impact on innate inflammation as well. So lots and lots of different ways of how it can work. So this is some of the evidence behind ITP, and you can actually see some of the clinical trial data that actually showed that why we need to give 1 gram or 2 grams per kilo and how that's superior to a lower dose. So this is the actual evidence basis for this, but Dr. Mel Berger loves actually telling a nice story about how there was a CVID patient who had ITP who got admitted and then just got his regular monthly dose. And the next day when they were on rounds and the attending looked at the resident and said, well, the platelets got better. What did you do? It's like, well, I just gave the patient the 0.5 gram per kilo dose that he was supposed to get usually. Well, whatever you did, it did better. So continue doing it. So then they did it for the 4 more days. And then the levels ended up normalizing. So that's how he said it. And then they got to the 2 grams per kilo through serendipity in science and medicine. But this is actually some of the evidence behind that. And can we use SCIG for ITP? Well, you can actually I actually published one case report of successfully using high-dose SCIG for a chronic ITP patient. And theoretically, it may be better than IVIG because you mitigate the peaks and troughs. And this is some of the data behind IVIG for Kawasaki's disease and why we use the 2 grams per kilo and how looking at the risk of aneurysm formation decreases. And CIDP, I mean, we're not going to go through what it is. Actually, it's a chronic demyelinating condition. It's like a chronic Guillain-Barré syndrome, essentially. And then there's various things that you need to use for it. And there's a lot of different studies. I mean, there was the ICE study that used Gamunex to study in CIDP and actually showed that there's significant improvement in the IVIG group versus placebo group. And they did an extension study that showed that you have continuation of the benefits. And then later on, we actually showed that you had subcutaneous immunoglobulin for CIDP in the PATH study. And why do we care? Why do we as immunologists care about looking at high-dose sub-Q for a neurologic condition? It's not just about the neurologic condition, but because many of these immunomodulatory uses for autoimmune conditions go by similar pathways. So with this data, this is the biggest study to date of using high-dose sub-QIG for immunomodulatory purposes. So I basically used what we found in this study as the basis when rheumatology sends someone and says, you know what, my patient can't tolerate 2 grams per kilo high-dose IVIG because of a variety of different adverse reactions. And can you use high-dose SCIG for those patients? And I have some foundational basis for understanding how high-dose SCIG can potentially have an immunomodulatory effect as well by looking at the data from the PATH study, as well as the patients who need for antibody-mediated rejection from solid organ transplants. And this is 172 patients. So PATH, I mean, this is again, 2 photos I took when I was in Italy. One is a straightforward path and the other one is a very serpiginous path. One is taken looking down from Capri, and the other one is a very straight canal in Venice. And again, the way this is the study design on the PATH study, we don't have time to get into it specifically, but it was a very elegant and laborious way of selecting for the patients. And needless to say, at the end of the day, they had positive results from looking at this, and it kind of highlights the benefits of being able to potentially use high-dose sub-Q IG for the patients who couldn't tolerate high-dose IVIG, even for immunomodulation. And this is another paper that we're not going to go down that road. But bottom line is, this is a summary slide. At the end of the day, it's all immunology. And whether it's replacement or immunomodulation, whether it's primary or secondary deficiency, whether it's, we call it PIDD, PIRD, or inborn errors of immunity, it all comes back to us. And we are the ultimate specialty to be able to take care of these patients and utilize the knowledge we acquire from this to be able to share and help and guide other specialties to better take care of their patients as well. So on that note, I want to thank everyone for your attention.
Thank you. But I know the fellows and I are going to stay here for a little bit. So thank you for coming to town. Last couple of days, San Diego has definitely elevated the education level of Seattle. And
so this photo is actually taken from in Portugal, actually, in the town of Guimarães, and where you have one of the statues of the ancient Portuguese, old Portuguese kings, overlooking the sunsets.
the fellows are going to think you get to do world travel as an immunologist.
Well, you do. So there's a lot of conferences, and and just look at him. He's everywhere all the time. I was texting him. I was like, why is Steve texting me back at odd times of the day? It's like, I'm in. Where are you? In Lausanne, or yeah. So.
Thanks again.
Yeah, thanks.